About 10 seconds, you'll be live. You should be live. You're live.
Okay. Thank you so much, and good evening, everyone. Welcome to the House Health and Government Operations Committee. My name is Jocelyn Pena-Melnick, the chair of this subcommittee, which is Public Health and Minority Health Disparities Subcommittee, and the vice chair of the committee. I want to thank, first of all, our members. I want to thank our members for being here tonight, because we couldn't do this work without them, and I'm very grateful. And we have a really busy agenda. So we're going to start with House Bill 48, followed by House Bill 49, followed by House Bill 109, followed by House Bill 373, followed by House Bill 430, and then we're going to go to 275, 578, 669, and 669 I'll do after 430, and the last one will be 765. So let's start with House Bill 48. As you know, these bills have all received a hearing. This is the subcommittee where we do the work to see if we can, if this is good policy, what is the support, can we compromise? And I have an open policy. Not everyone does, but I invite everyone, whether you're for it or against it, and we try to discuss it and compromise, okay? So we have House Bill 48 is the first one, and it's titled Public Health Maryland Suicide Fatality Review Committee. And this is Delegate Lisa Belcastro's bill. Erin, can you please start by telling us what the bill does?
The bill would establish the Maryland Suicide Fatality Review Committee to identify and address the factors contributing to suicide deaths and facilitate system changes in the state to prevent suicide deaths. The state team would include specified members and be staffed by the Maryland Department of Health. There were no amendments offered at the bill hearing.
Okay, and what is the current status, if you know, in the Senate of the bill?
So we have possession of the Senate bill. It has passed the full Senate without amendments.
Okay, and do we know what that vote was?
I believe it was unanimous. I will check. I will double check.
Thank you. Delegate Belcastro.
Thank you very much, Chair Pena-Melnick.
My pleasure.
During the hearing, this is a good bill. It's been utilized in many other jurisdictions across the nation, as these other jurisdictions that have implemented similar committees have implemented the recommendations that have come out of this committee. They have seen their rate of suicide drop, while the rest of the country has seen their incidence of suicide continue to increase. So this is good policy for Maryland as our rate of suicide continues to increase. We had, during the hearing, issues with the fiscal note were raised. We worked really hard in the interim to get that fiscal note reduced to $300,000. We still said that wasn't good enough in the hearing. So in the last 2 weeks, we worked even harder to get that fiscal note dropped an additional $100,000, just under $200,000 year over year. So we really hope, we've worked really hard at getting that reduced. We hope that we can have your support for this bill.
And did you work with the department?
We did work with the Department of Health. We had a virtual meeting, and we had emails back and forth to get that fiscal note down. We believe that we found that a similar bill was implemented in 2014 for our local overdose fatality review boards. They utilized CRISP in the same exact way that the Suicide Fatality Review Committee would utilize CRISP. And that fiscal note in 2014 was actually zero for the state. Since then, they found that there are some costs associated with the enhancements since they've started implementing those local fatality overdose review boards. And so they were able to compare the two and reduce that price for us by looking at how they implement those local fatality review boards across the state, across the state.
Okay, wonderful. Thank you so much for your work, for making time to work with the department, for bringing the fiscal note down. I know you have been working really hard on it. I'm going to open it now, and there are no amendments to the committee. Are there any questions or concerns regarding House Bill 48 for the good delegate?
Real quick,
Delegate Shalega.
It was unanimous in the Senate. I did check.
Okay, thank you. Delegate Shalega.
Thank you so much, and thanks, Delegate Belcastro, for bringing the bill. I didn't notice the Department of Veterans Affairs on there. Was there a reason that you guys didn't put them on there?
There was no specific reason. Now, I will say that the individuals that we did choose, they have a strong background in suicide and are directly related to suicide and have a specific interest. But there was no reason particularly that Veterans Affairs were left out, no.
Yeah, I noticed in the preamble, and you know, clearly we all know that veteran suicide is a big problem. So, you know, just, I don't want to slow your bill down, but it seems like they would be a good addition to make sure that we're making sure that we include the veteran suicide issues. Thank you.
To speak to that directly, I'm trying to see if anyone, I believe Paul Nestat is here. He might be willing, and Janelle Cubbage as well. They've played a big role in drafting this legislation. They might be able to answer that question for you about the makeup of the committee.
Paul Nestat.
Hi, how's it going? I'm Paul Nestat. I'm a psychiatrist at Johns Hopkins and was helping with this bill over the last few versions. Yeah, so the committee is made up of a couple of different people that are largely sort of the recommendations of the Governor's Commission on Suicide Prevention. So there's some flexibility within that about who can be appointed on behalf of some of those groups. I think it's a good set of people that can help look at the multiple systems involved in a suicide death. Essentially, you know, it's not just the person's doctor, but we look at where people have interacted with, let's say, the school system, where they've interacted with the police, where they've interacted with hospital systems. It's very similar, in fact, identical to the way things are done for the opioid fatality review team, and similar to how things are done for the child fatality review team. It's just there's lots of systems at play here. So we want to have representation from all of those systems as much as possible.
Thank you. And you know, I don't think opioid would be as closely linked with veterans, but I would just ask you, as you roll this out, you know, if you need to include somebody from the Department of Veterans Affairs or someone with a specialty in that you would consider coming back and adding them. Thank you.
That's a great idea. And I would, if I could just add, I work with the Air Force currently when airmen die by suicide, and both the VA and the DoD are really good at keeping good records, which make people that sort of are relevant to those organizations particularly easy to look into for these deaths. So I definitely agree, having someone from the VA would be very helpful.
Thank you. That's a good point. If you could, I know there are opportunities for membership, right? If you could keep that in mind and make sure that you appoint someone, I appreciate it. And if you could email me, send me an email, let me know that that's done when the bill goes into effect, okay? So I can send it to Delegate Shaliga, okay? Are there any other questions? Seeing none or concern, may I have a motion on the bill?
Move the bill.
Second.
Is it moved? It's in second. All those in, any objection? All those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes unanimous. Thank you, Delegate Belcastro. You worked really hard, and thank the department, all right? Take care. Next we have, you're not leaving because you're on my subcommittee and I need you, Belcastro. I should have put your bill last, no, just kidding. Next we have House Bill 49, and that is Public Health Emergency Allergy Treatment Program Nurse Practitioners. And Erin, can you tell us what the bill does?
This bill authorizes a nurse practitioner under the Emergency and Allergy Treatment Program to prescribe auto-injectable epinephrine in the name of a certificate holder and/or dispense auto-injectable epinephrine and the necessary paraphernalia for its administration to a certificate holder. The bill establishes legal immunity for a nurse practitioner acting in good faith in dispensing auto-injectable epinephrine. There are amendments on pages 1 through 4 of your amendment packet. On page 2, you'll see that the definition of nurse practitioner is changed to registered nurse practitioner, and that person has the meaning stated in section 8108 of the Health Occupations article. This was suggested by the Maryland Department of Health. And these amendments, are Delegate Johnson's amendments, who is the sponsor of the bill. And if you look on page 3 of the packet, in line 29, this extends the nurse practitioner immunity provision to the nurse practitioner's prescribing authority. This is an oversight in the original draft. You'll see on line 20 that the liability immunity provisions for physicians extends to prescriptive and dispensing. So it was just an oversight in the drafting.
Okay, Delegate Johnson,
Thank you, Madam Chairman.
my
I
pleasure.
wanted to explain this bill just a little bit because it is kind of confusing. Nurse practitioners have prescribing authority in Maryland now. But their authority is to someone who comes to them with an individual prescription from a physician. And then they can dispense, or they can prescribe to an individual to go get the medicine filled, the EpiPen. This is different because it allows them to prescribe to a certificate holder. So it's not a personal prescription, but a certificate holder. If you will look on page 2, it defines what a certificate holder is in line 17 through 19. And that's going to be important as I talk of the second point on this bill. Certificate holder means an individual who is authorized by the department to obtain, store, and administer auto-injectable epinephrine to be used in emergency situation. So this will give the nurse practitioners the authority to prescribe to a certificate holder instead of an individual. So they can get 6 or 10, however many EpiPens that they think they need for a summer camp. That then is the responsibility of the certificate holder to take chain of custody of those EpiPens and make sure at the camps they're stored properly, they're not outdated, and that they're and given if needed by trained authorized folks. That's the difference. So they can prescribe to not an individual, but to a certificate holder. All right. So we have a lot of letters of support, but we have one letter from Maryland Association of Justice that is favorable with amendments. The reason the certificate definition is important is because the amendments that the issues in the amendment address the certificate holder about the proper storage, not giving an out-of-date EpiPen. It talks about the certificate holder. A cause may not arise against any nurse practitioner for any act or omission when the nurse practitioner is in good faith dispensing the auto-injectable epinephrine and necessary paraphernalia for the administration of EpiPen, I'm going to just call it EpiPen, to the certificate holder. But the others talk about, like I said, storing it at the right temperature, not giving out of date EpiPens. Those are an amendment that address the certificate holder. And I wanted to make sure I was clear on that. So I reached out to council and they concurred that those address the certificate holder. So if we need to do a bill later that addresses those on a certificate holder, that's okay. But this bill is about the nurse practitioners being able to prescribe to a certificate holder. So with that, I would like for the committee to reject the amendment, as I feel it does not address what the bill does. It does not address the nurse practitioners prescribing to a certificate holder. It addresses what the certificate holder does with it after the EpiPens are in possession of the certificate holder at the summer camps. If anyone has any questions, I hope I cleared it up and didn't confuse you.
Let's see if there are any questions. So basically, this bill will extend the prescription to certificate holder, period. It doesn't deal with the storage or anything like that. That's another bill. That's another entity. This basically allows them to be able to prescribe so that a person could be a certificate holder at our summer camp, correct?
It allows nurse practitioners to prescribe to a certificate holder.
Okay, wonderful. Are there any questions from anyone in the committee? Delegate Lewis. You
Thank
are-
you.
Okay, go ahead.
Oh, thank you, Madam Chair.
My
Thank you,
pleasure.
Delegate Johnson. I just want to make sure it's clear what the criteria for being a certificate holder entail. Is it, and then looking at the fiscal note, well, it's not clear. Can you talk a little bit about that?
Erin? Just give a minute. Hold on a second.
It might be in other parts of the code that aren't in front of me.
Sorry about that.
It is
Right.
another part of the code. I'm looking as well. I know Dr. Mark Ubens, what, are you
I mean,
able
I
to
know
help?
they have to complete an educational training program.
Hi, yes,
approved by the department.
Okay, Mr. Ubens,
yes, hi. I wasn't sure if I could just hop in, but yeah, I'd love to clarify that.
are you a doctor or nurse practitioner, and who are you? Who you represent?
Yes, hello everyone. Thank you for having me. My name's Mark Ubbins. I'm a nurse practitioner and a
Okay.
camp health supervisor for several camps in Maryland. So the question about what do you need to do to be a certificate holder? So to be a certificate holder, you must fill out a DHMH form, epinephrine certificate holder application. Those are found on the DHMH Youth Camp website. That form, you agree in writing to properly store and maintain the epinephrine. You have to show proof that you're 18 years of age. You have to provide proof of a EpiPen certificate holder course. The certificate holder course is also approved by the Department of Health and Mental Hygiene, and you have to be a registered nurse, a nurse practitioner, or a physician to be able to teach that course.
Delegate Lewis, does that answer your question?
Yes, and I was able to just take a look at the certificate holder application, and it's very straightforward. So thank you very much.
My pleasure. Good question. Any other questions or concerns? Delegate Bagnall.
Thank you so much, Madam Chair. And I think this probably is a question for Mr. Ubens as well. Is it fair to sort of make a comparison of the certificate for the epinephrine is like that training is sort of like if you were getting CPR certified? You're not necessarily a medical practitioner, but you are getting trained in the in administering the EpiPen, and that is how you get the certification. Is that accurate or is that inaccurate?
Yes, there's actually, so you also, in the certificate holder application, you have to list the designated agents. So those are those who are able to administer the epinephrine. So your designated agents, that could actually be your RN who's at the camp, or it could be a certified medication technician through the Board of Nursing, or it could be someone who completed an approved Department of Health and Mental Hygiene camp medication administration course. But either way, it has to be someone who's listed as one of the designated agents on the certificate holder application. So the certificate holder, kind of exactly as you guys have described, it's the person who kind of takes the accountability for receiving that pen. You have to provide your protocols. That's another piece of that application. And it also allows, if you're a Bible school that has 20 kids and you want to have an epinephrine available for anaphylaxis, a prescriber could prescribe that to the certificate holder themselves. So you could send the prescription to John Smith to a local pharmacy, and that would allow them, that prescription made in the name of the certificate holder allows them to get that through a retail pharmacy as opposed to having to try to go through like a wholesale pharmacy.
Thank you very much.
Thank
Yes,
you. Are there any other, go ahead, Erin.
No, I'm sorry. Someone was up.
Okay. Okay. Any other question? You can put your hand down, Mr. Ubens, and you've been amazing. Thank you for your help.
thank you
So
so
that I don't
much.
get confused. Thank you so much. I appreciate you. You have been wonderful. Are there
Thank you.
any other questions regarding this bill? Does anyone else want to be heard?
Madam Chair,
Yes.
my name is Josh Howe. I'm with Compass Government Relations representing the Maryland Association for Justice. I'd like to just try to discuss some of my the amendments and kind of just our perspective. And so what we saw in the draft of the bill was the new immunity provision outlined on page, I believe it's 3 on line 27. It says a cause of action may not arise against a nurse practitioner for any act of omission when the nurse practitioner in good faith dispenses auto injectable epinephrine and the necessary paraphernalia for the administration of continued. And so we saw this, and as you know, the Maryland Association for Justice is critical of legislative grants of immunity. We often try to point to other existing immunities. And what we noticed when we looked at this subtitle of law is that it mirrors a subtitle that was considered in 2018. It was your bill regarding auto-injectable epinephrine at institutions of higher education. And those immunity provisions outline the manufacturer's guidelines for storage and expiration. And we were just asked that the committee consider that precedent as it kind of was established at the institutions of higher education and conform this program to that program.
Yeah, except that they're different, right? I mean, this is the nurse practitioner, and they basically do the prescription and it stops there. They're not the ones in charge of handling it or taking it. So they're very different from the university. I remember that bill very well. Delegate Johnson, then Delegate Hill.
Thank you, Madam Chairman. If you will look on the same page, page 3, in line 19 through 22, the language for the nurse practitioner who is prescribing is exactly the same language as the physician who is prescribing. So we wanted to keep it consistent with language that already exists for the physician.
Can I respond to that? It actually does not mention prescribing, I believe. It just mentions dispensing.
I have, the council wants to speak.
The amendment
Erin.
is going to include prescribing. That was an inadvertent omission.
It will be taken care of, Mr. Howe. Okay, so then it will be consistent. Thank you, Erin. Delegate Hill.
Yeah, so I just want a clarification, and I want to, so Erin says so there are some amendments with the suggestions. We take the sponsor's amendment, which would clarify that it's not this distinction that you're talking about. Is that, Erin, is that what you're saying?
Yeah, you have a packet, page 3, lines 27 through 31. There's an amendment on line 29 that adds prescriptive authority.
Okay, but the
prescribing.
And in that case, the immunity here would mirror that of the physician and the pharmacist?
It would mirror the physician, but the pharmacist is only for dispensing.
Okay, so Mr. Howe, is your concern about the certificate holder, meaning the camp itself, or you're trying to say that the nurse practitioner should be liable for things that the physician and pharmacist aren't?
I think that when I'm presenting MHA's position, they may be presenting a broader position to conform the entire program regarding youth camps and epinephrine to the program established under higher institutions of higher education. Because under that subtitle, there are a number of guidelines when it comes to prescribing, dispensing, and administering auto-injectable epinephrine, including the storage and expiration according to manufacturers' guidelines. And we think that that was good policy, and that the program, if it's being opened up with conversation of immunity as it is on page 3, lines 27 through 31, that the committee consider conforming the entire program to the amendments that were adopted in the 2018 version of the Institutions of Higher Education.
But if I have not read your proposed amendment. I remember the hearing. But my understanding is that if we did that, that the nurse practitioners would be held to a different standard than the pharmacists and the physicians, and the certificate holder would not be the one that is responsible for making sure, I'm not, for a certificate holder, I mean the people who own the camp. That's who I think, when I say certificate holder, that's what I'm talking about, that they're not, that they're not responsible for making sure that the right product is there, that it's properly labeled, and that it hasn't expired and all that stuff. Now, the nurse may be their agent, but is your amendment trying to say that we should hold the nurse to a standard, not the certificate? I don't understand. In other words, why aren't you just putting in a bill to do all that instead of just coming after the nurse practitioner?
I guess it's our perspective that this legislative proposal is amending the program by allowing nurses to also prescribe, and that our amendment would also be appropriate to propose because it's amending the program, and we believe that the new immunity provisions outlined and on the page 3 of the bill should conform to the language that's outlined in the Institutions of Higher Education program, which mirrors this proposal, but was updated in 2018.
Okay, I have to look at your amendment. I don't see it, and I'll just have to look. Thank you.
All right, thank you. Are there any other questions? Anyone else? Thank you, Mr. Howe. All right.
Thank you, Madam Chair.
My pleasure. Seeing no other questions or concern, Delegate Hill, will you be so kind and put your hand down?
Yes, I just wanted Aaron to clarify where Mr. Howe's amendment is that Delegate Johnson would like us not to accept, because I'm still confused about whether his amendment, I don't see it, and I don't know where.
It was not in the packet because it didn't have a sponsor from the committee.
Okay, so it's not even before us for consideration.
Correct.
No, it's not.
I mean, it was presented at the bill hearing, but
Yes.
in your packet today.
Okay.
And Delegate Johnson doesn't want it. He
Got it.
says it's not necessary because, it would put them in a different category than the doctors in the pharmacy. It's not consistent, is what he's saying. Okay?
Right, so they need to change the whole thing and go after
That's
the
right.
certificate holder. Okay.
Yes. All right. I see no other questions or concerns. Is there a motion on the delegates' amendments, Delegate Johnson's amendment? Actually, one second. Aaron, did you describe the amendments? Can you refresh my memory? There was so much discussion.
It clarifies the definition of certified, or is it, it's registered nurse practitioner? No, I always forget because it goes back and forth. Hold on. Registered nurse practitioner. And those were the amendments suggested by the Department of Health at the bill hearing. And then it also fixes an error in the immunity provision that would extend immunity for prescribing for nurse practitioners.
Okay, great. Delegate Shalega. You're muted.
Move the amendments.
Thank you, Delegate Shalega. It's been moved by Delegate Shalega, second by Delegate Bagno. All those in favor, say aye.
Aye.
Any objection? None. On the bill as amended, may I have a motion, please? It's been moved and second. All those in favor, say aye. Any objection? Seeing none. AJ say yes, she votes on it. Hi, AJ. Okay, so the bill passes and is unanimous. Now we're on to House Bill 96, Public Health Non-Discrimination in Access to Anatomical Gift. Actually, no, we're not going to do that one yet. I'm going to do we're going to leave that later for discussion with the other bills. Let's do House Bill 109, which is the Maryland Department of Health System for Newborn Screening Requirement. Aaron, can you describe the bill? And then I'm going to call on Delegate Shetty.
This bill requires the Maryland Department of Health newborn screening program to screen for each condition listed in the U.S. Department of Health and Human Services recommended uniform screening panel. And on or after January 1st, 2023, the department must include any core or secondary condition added to the screening panel to the state's newborn screening panel within 2 years after the condition is added to the panel. There are amendments that were provided in a separate amendment. The issue was just the amendment office was not able to get it finalized in time, so that's why it's in a different form. But if you look at that amendment that was sent separately on page 3, the bill, and these are from Delegate Shetty. On page 3, the bill has been amended to just require the department to screen for each core condition. It deletes the language about the secondary conditions. And it also provides that on or after January 1st, 2023, the department would include in the system for newborn screening any core condition added to the recommended uniform screening panel within 2 years and 6 months after the addition of the condition to the panel. And then there's additional language, if you look on line 16 on page 3, that if 2 years after the core condition has been added to the U.S. Department of Health and Human Services recommended uniform screening panel, the department has not implemented testing for the condition, the department would submit to the Legislative Policy Committee and publicly post on their website a report that includes the steps the department has taken to begin testing for the condition, the cause of the delay in implementing testing, and the department's plan to implement testing before the required deadline. Subject to the approval of the Legislative Policy Committee, the department may include as a part of the report a request for a 6-month extension to the deadline to implement testing.
Thank you, Erin. I appreciate your work. Delegate Shetty, can you tell us where the amendments came from and why we need the bill, please?
Yes, ma'am. Thank you, Madam Chair. And thank you, colleagues, for allowing me to join you this evening for consideration of this bill. So we worked with, after the bill hearing that we had that was seemed very productive, we got lots of great questions from colleagues on HGO. We worked with the department, including their newborn screening program, and with advocates to try and better balance both the need for the department to quickly and expeditiously approve core conditions once they're added to the federal recommended conditions list. But we wanted it to be done in a way that recognized that some things are outside of the control of the department. So they can go through all of the things that they can do that are within their control. However, if there is a short supply of lab equipment, that's not really something that they can control. So working with all stakeholders and getting sign off in the end from the department, we came to this compromise language, which would essentially meet the goals of the bill by providing certainty to the patient community and to Marylanders, babies that are born here in the state, that our state is doing all that we can to keep the newborn screening panel up to date.
Wonderful. That's what we like. We like to work with the department, so thank them for me.
Yes,
are there any questions for the delegate on this bill or the amendments that the department has agreed upon? Okay, seeing none.
Move the amendment.
Excuse me, Delegate Hill, do you have a question?
Move the amendment.
Oh, thank you. Is there a second?
Second.
It's been moved in second. Any questions or concerns? Wonderful. All those in favor say aye. Opposed?
Aye.
On the bill as amended, may I have a motion?
Move the bill.
Second. It's been moved in second. Any discussion or concerns? Seeing none, all those in favor say aye.
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 Any opposition? Seeing none. Thank you. The bill passes unanimous. Thank you for working with the department. We really appreciate it. Next, we have House Bill 373, State Postmortem Examiners Commission Minimum Staffing Requirement, and that is Delegate Resnick. Erin, will you tell us what it does? Thank you so much.
The bill as introduced would require the State Postmortem Examiners Commission to ensure that the number of staff and employees does not fall to a level that constitutes a Phase 2 violation under the National Association of Medical Examiners. There is an amendment in your packet on page 5 from Delegate Resnick that requires the Maryland Department of Health and not the State Postmortem Examiners Commission to ensure the staffing levels that are required in the bill.
Okay. Delegate Resnick. Thank you, Erin.
Thank you, Aaron. Thank you, Chair Pena-Melnick. We just heard this bill last week. I don't want to rehash all the news reports that have been taking place. I think you've all read them. Our department of the Office of the Chief Medical Examiner is in dire straits right now. The department has, to their credit, finally approved 21 PINs to be hired into the department. But to this point, the department has done little to actually expand the number of people available to actually take those jobs. And so I think we're still in a very delicate and dangerous place with regard to the lack of autopsies that are being done by the department. Up until only a few weeks ago, they did not even have proper facilities to store all of the remains that they have to do autopsies on. So the department has neglected this office for a very long time. I don't know how many of you heard, I'm assuming most of you have heard this weekend, there was an additional development in that Dr. Whedon, who was the chief medical examiner, has resigned this weekend. That puts us one more experienced person down in that office. This bill would simply require, as was stated, that they cannot fall below a phase 2 violation. A phase 2 violation basically means 325 autopsies per year per medical examiner. So the way to do that is you either hire more medical examiners, more pathologists, or you lower the number to a reasonable level. Keep in mind, this is a phase 2 violation. Phase 1 violations would put the office into a sanctioned state without losing accreditation. But a phase 1 violation is 250 per year per medical examiner. So we're just asking them to stay below a level that keeps the office accredited. And just for the information of the subcommittee, losing accreditation means losing the ability of those medical examiners to go to court and testify and be deemed legitimate testimony for the autopsies they perform, for the pathology that they testify to. So it is critical that this office functions properly. The amendment as introduced would switch out the commission, which is the volunteer oversight board. They don't have budget authority. It's the department that has to be held responsible. So that's what the amendment does. So I ask that the subcommittee move the bill and the amendment.
Are there any questions? Delegate Rosenberg, followed by Delegate Hill.
Yes. Would the bill benefit from requiring a quarterly report on the status of hiring so that we get some sense of whether progress is being made?
Delegate Rosenberg, I think that's a good idea. I mean, I get an annual report as the budget subcommittee chair, and they report to us on an annual basis. You're right, that's not nearly enough. That's why we're in this situation to begin with. So I wouldn't mind seeing a quarterly report being added. My one concern is additional workload for that office to be provided given the situation, but I don't know that a quarterly report would, on the status of staffing, would be necessarily that burdensome.
Terrific. Thank you.
Okay. Delegate Hill, followed by Delegate Bagnall.
Thank you, Delegate Resnick. I appreciate the bill. In fact, wrote an op-ed about the problems in this place in 2019, asking for an investigation. So they've had pins open for a while. I think this bill is necessary. I'm just not clear how, other than the quarterly report, do we need an is there something else we can do? Because this, I'm not sure how this changes their lack of performance that we've been watching. And I just think that needs to be articulated, how that actually.
It is very difficult through legislation to force action. By requiring this level of staffing in statute, failure to abide by it could potentially put the department in contempt. That is I model this on several years ago, and this came before my subcommittee. The department failed to abide by statutory requirements to make available beds for forensic patients, for behavioral health forensic patients. And they were taken to court, and then the secretary was found in contempt. And as a result of that action, they took action to free up beds. So there are things that they can do. They have to do it. I wouldn't say, keep in mind, as this bill will be introduced, and if it's passed, it won't take effect until October, right? So they have time to ramp up and be able to do what they need to do between now and October to not be in violation of the statute.
All right, thank you. That explains it.
Delegate Rosenberg, will you be so kind and lower your hand? Are you done, or you had another question?
Well, actually, in light of that, when should the first of the quarterly reports be due? If the bill's not taking effect till October.
I mean, that's part of the issue. The bill doesn't take effect until October. Actually, let me verify that it's October instead of a July. Yeah, it is October. So I mean, that is something the committee could change.
Could it be emergency legislation? Is there a reason?
We could potentially do it as emergency legislation. It would take immediate effect. That's up to you all to determine how you want to structure that. To be fair, there aren't enough pathologists out there to be able to fill these roles. So I do want to give them the time to be able to do right by this department. My intent here is not to drag Secretary Schrader in front of a court. It's to have them fix the problem. So my preference is to give them the time, but at least let them know that this is happening. If we do a quarterly report, I think it would have to start, frankly, when the bill takes effect.
As a baseline.
You could make the reports take effect before the bill takes effect.
No.
Do you know what I mean?
I do.
It would just be a different section. So your codified section could still take effect October 1st. And then you could do another section that could require reports just in terms of who are you hiring.
We can do that.
How fast.
I think
And
that's
that can be
fine. I think we
sooner.
can do it July 1 if that's appropriate.
You can do as early as June 1 without it being emergency.
Okay. So that's up to the committee. I'm fine with any of that.
All right, thank you so much. We have Delegate Bagnall, followed by Delegate Chisholm, followed by Delegate Kaiser. Delegate Bagnall.
Thank you, Madam Chair. And I was actually going to raise the same question of would this rise to the level of an emergency bill, and what would be the appropriate timeline? So I feel like we're going to have those discussions as it is. That was my question.
Thank you. Delegate Chisholm, followed by Delegate Kaiser.
Thank you, Madam Chair.
My pleasure.
And I understand the importance of this bill and the need for more examiners, but the elephant in the room is truthfully, they can't find enough people. I don't know if this bill really addresses what is the real problem with finding these people. We can make it an emergency bill. We can do all the studies. The bottom line is they can't find enough pathologists, and they can't hire enough people. So I guess my question is more for Delegate Resnick. Have you talked to anybody? And obviously there was a turnover this weekend, which I heard on the news this morning that you correctly addressed. But have you asked them what solutions they need? There's plenty of pins, obviously, and it's not I don't even think it's a money problem. How do we solve the problem? I don't think this bill solves the problem. I guess is we can say, well, we're going to enforce or we're going to levy this on you, but until we find people that want to fill these positions, what can we do to help to facilitate having more people hired? I guess is my question.
Delegate, you're not wrong. There is a shortage of pathologists out there, and that is a fact. What I have seen, and yes, I have spoken to the department. I've been chair of that subcommittee now this is my 6th session. Every year, our budget analysts point out that there is a staffing problem in that office. And every year the department tells me that they are working on it, that they have started a fellowship program, that they've raised salaries a tad. And nothing seems to happen. We still seem to have an attrition. What has really happened in that office that has killed us, frankly, is the fact that they have instituted this per diem program that in order to try and solve the problem, they said, we're gonna hire per diems, we're gonna hire essentially consultant pathologists. We're gonna fly them in from other states. So these are pathologists that work full-time in other states. We're gonna fly them in on our dime. We're gonna let them work at almost $1,000 a day, actually $800 and something per autopsy. We're gonna bring them in on a per diem basis over the week, in the weekends, at nights, and they can make a little extra cash on the per diem side. So what has happened is all the pathologists that were full-time and getting close to retirement, last year, 5 of them retired and all came back as per diem. So they're collecting their retirement and they're collecting $850, and they're getting the easier cases because the per diems get the easier cases to clear. So it's creating an even larger problem of morale in that office for the full-time pathologists because they're getting the harder work and they're getting paid less. So this office has essentially created this problem. And to solve it, we do need to do things that get people in. One is we have to stop the bleeding. For those that haven't retired, many have left the office and have gone to other ME offices in other counties and other states where they may get more money, they may get the same money, but they definitely get a lower caseload and a better quality of life because of it. This office has created the problem. It's not a money issue, but the fact that they have raised salaries significantly only this year when the crisis hit, and the fact that they have opened these 21 pins only this year when the crisis hit, demonstrates a lack of forethought that has to be fixed and held accountable. So the pins exist now, the money is there. The question is, what do they need to do to maybe woo people away from other offices the way that those offices have done to us, bring people out of retirement or back from, whatever they have to do, get medical students on these fellowship programs out faster, whatever they need to do. This bill does not, tie their hands in terms of what they need to do. It simply tells them, get it done.
Thank you, Mr. Chair, or Madam Chair. That was a great answer. Thank you very much. It was informative.
Thank you, Delegate Chisholm. Delegate Kaiser.
Thank you, Madam Chair.
My pleasure.
I love data more than the next legislator. But when I hear about this, the report, which I think we often need, but when I hear the idea of the quarterly reports, which I think is generally helpful, I'm concerned, what in fact would we do with that information? So if we were to begin to get that sooner rather than later, and we get it, let's say July 1st and October 1st and January 1st, what, if anything, are we doing with it? So I wonder, not just the workload issue that Delegate Resnick correctly pointed out, that this is already an understaffed office and that we'd be giving some reporting to, which should be not the hardest report in the world. It's not as hard as talking about their cases, but I wonder if a quarterly report not just serves a purpose, but gives us an opportunity to do anything new or different during that time. So that would be my concern.
So if I may,
Yes.
I understand your concern. And for me, if we do a quarterly report, and again, that's up to the committee, I'm fine with it. I'm mostly agnostic. But if we do it, I think what it will tell us is whether or not they're on any kind of a track, that they're actually getting to a point.
But then what? Do we do anything with that information?
Not in July, right? So we're not here in July, so we can't do anything with that information. Frankly, we couldn't do anything with that information in October either. So, I mean, that is a reality, and we may want to wait for the annuals because that's when we actually are able to act. that's, that's again for us to decide. Like I said, I don't think it's a terrible idea, but I am agnostic in terms of the work of the committee.
Okay. Delegate Rosenberg.
I would just say it shines a light, and even though we're not here, it hopefully prompts the department to be a little more serious about solving the problem.
Any other questions or concerns? I have one question, Delegate Resnick. I know that I read recently that we had to get help from the federal government, from FEMA. Any other states have done that?
Not to my knowledge. Not to my knowledge that have any other states even requested it.
Okay. All right, thank you. I would like to say that the idea of the report is good, but it's an office that has already a lot going on. And we're getting the reports annually. We can really only do something when we're here in January. So I would say that putting another burden, it's just not the right thing at the moment of a report. I think that we do get the annual report and we can do an act from January to April. So that being said, on the amendments that are proposed, Erin, were you going to say something?
No, I was just moving.
Okay, sorry. Okay, the amendments that are proposed.
Sponsor amendments.
Any other questions on the amendments?
Move the sponsor amendments.
Okay, is there a second?
Second.
It's been moved and second. Any questions or concerns? All those in favor say aye. Any opposed?
Aye.
Seeing no opposition on the bill as amended, may I get a motion, please?
Move the
Motion to
bill.
move the bills amended.
It's been moved and
Second.
second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposed? The bill passes unanimous. Thank you, Delegate, for the hard work and for your commitment, okay?
Thank you very much.
Our pleasure. We have next House Bill 40, which is the Human Services Secretary of Aging Qualification Bill. Erin, will you tell us what the bill does, please?
Sure. This is House Bill 430, and it requires an individual appointed as the Secretary of Aging to have extensive experience with and knowledge of laws, legislation, and regulations relating to aging, of programs for aging, and of programs for aging individuals, including evidence-based and data-driven programs. The individual must also demonstrate a commitment to the missions of both the Federal Older Americans Act and the Maryland Department of Aging, and at a minimum hold a bachelor's degree. This bill was in subcommittee last Monday, and there was discussion about the bachelor's degree requirement. Delegate Kerr has offered an amendment that would strike the requirement that the Secretary of Aging hold at a minimum a bachelor's degree, and that is on page 7 of your packet.
Thank you, Erin. Is the Delegate Kerr here? All right, he's not, but he spoke last week, and he did take the comments of the committee because we held it. Are there any questions on the delegate's amendment? Seeing none on the amendment. Oh, Delegate Robin Lewis.
Thank you, Madam Chair. I couldn't get the button to raise my hand, but thank you.
Not a problem. Thank you.
I do feel that it's important to retain the bachelor's degree requirement, mostly because, as I understand it, that requirement puts the Secretary of Aging in line with the Administrator for Disability, as I recall. Maybe Erin can remind us of the exact title of the counterpart agency head.
It's the Department of Disabilities.
Yep, Department of Disability. So it strikes me as incongruous that a person with a very similar scope of work and status and responsibility would have a lesser credential. So I feel pretty strongly that the bachelor's degree requirement should be retained.
Okay. Michelle Douglas. Thank you, Delegate Lewis.
Thank you, Madam Chair.
My pleasure.
And Delegate Lewis, I completely understand your perspective. I think what Delegate Kerr was looking to do was to accommodate the concerns that he heard last week, and knowing that the first qualification about needing to have extensive experience and knowledge of aging laws, legislation, regulations, and programs for aging likely would result in most people having a bachelor's degree. I think it was Delegate Krebs who mentioned, and maybe it was Delegate Shalega, that there might be, a person here or there who's been in the field for 20 years or so and has the extensive experience and perhaps did not have a bachelor's degree. And so wanting to, accommodate those various concerns.
Okay. Thank you, Michelle. And are you okay with the amendment, Michelle?
Yes, we are, Madam Chair.
Okay. Are there Delegate Johnson?
Thank you, Madam Chairman. I was just looking, does it say that in the bill that either a bachelor's degree or extensive, probably X amount of years experience in the field?
It does.
Yes.
Okay. All right. Thank you. Thank you, Madam Chair.
My pleasure. Any other questions?
Move the amendment.
Delegate Hill, the amendment has been moved. Delegate Hill, did you second it?
Yeah, sure.
Okay. All right. It's been moved and second. Any concerns? All those in favor say aye.
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 Any opposition to the amendment?
Move the bill.
Yeah, sorry. Thank you, Madam Chair.
Okay. All right. The bill has been moved by Delegate Shalega. Is there a second?
Second.
It's been moved and second. Any concerns or discussion? Okay, on the bill as amended, all those in favor say aye.
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 Any opposed? All right, seeing none, the bill passes unanimous. Thank you,
Madam
Delegate
Chair.
Lewis.
Madam Chair.
Yes, Delegate Hill.
Thank you. I just wanted to clarify. That's what I was going to say earlier. Delegate Johnson asked if the bill says it's one or the other, and you all said yes. And it doesn't say that. It does require that they have extensive background, not in lieu of a bachelor's degree, but the main requirement is that they have an extensive background. And by doing them in, we're saying with or without a bachelor's degree, you got to have this core competency. So, correct, Aaron? It doesn't say.
Right,
I think that's incorrect. I think it says you have to have it in the original bill.
In the original bill, but we removed it.
So
no, the core competency is still there.
Yes,
let's let Aaron address us, okay? Aaron.
So now the bill with the amendment would require that an individual appointed as a secretary must have extensive experience with and knowledge of legislation and regulations relating to aging and programs for aging individuals, including evidence-based and data-driven programs, and demonstrate a commitment to the missions of both the Federal Older Americans Act and the department.
Okay. All right, Delegate Johnson.
Thank you, Madam Chair. That cleared it up. That was the question I was asking. Thank you.
All right, wonderful. Okay, so that's it. No other question. The bill passes unanimous. Thank you. And thank you all for being flexible. We try to compromise here. And I think that, that's important, and all voices have to be, heard. So this is a compromise. House Bill 669, Maryland Medical Assistant Program Doula Services Coverage. And we also have House Bill 765. So we're going to deal with 669. The sponsor of House Bill 765 said that he did not mind if we did not work on his bill because we had 669, and the sponsor of 669, Delegate Wilkins, had been working hard with the HSCRC and all those involved. So Erin, can you tell us what the bill does, please?
This bill requires the Maryland Department of Health to ensure that doulas providing care under Medicaid are participating doulas, review participation in Medicaid of participating doulas and program recipients, and evaluate the effectiveness of doula services covered by Medicaid. The bill also establishes the requirements for participating doulas and specifications for covered doula services. There are amendments in your packet that have been sponsored by the bill sponsor, Delegate Wilkins. On page 9, there is an amendment that strikes the definition of postpartum period from the bill, and it strikes the requirement that an MCO provide home visiting services. There is an amendment on page 10 that clarifies that doula services will supplement the services of healthcare providers and provides that a doula will provide prenatal coaching and not prenatal counseling. And then Delegate Wilkins, were you going to sponsor the HSCRC amendment? I just wanted to make sure.
I think it would be great to discuss it, and I am neutral on it. We did talk earlier, so I wanted to make sure the committee had the opportunity to talk it through and decide how they wanted to move forward.
Okay, so the final amendment on page 11, as Wilkins stated, is up for discussion. And this would provide that the bill would not be construed to limit the authority of the Health Services Cost Review Commission to set the appropriate rates for hospital services.
Okay, and that's the law. So anyway, Delegate Wilkins, go ahead and tell us what you think, why the bill is needed. Who have you worked with? Why should we pass this bill? And I know Pam Case-Meyer is here as well, and I'll call on her next. And thank you for your work.
Thank you. And thank you so much, Madam Chair. Hello, members of the subcommittee. Again, as a reminder, this bill, what it does is it codifies the regulations of the Maryland Department of Health to ensure that doulas will be reimbursed for Medicaid. MDH is rolling out this program now, which is very exciting. We want to make sure that it is codified into law. So that's the purpose of the bill and why it's needed, that we have this program in existence for the long term. The 2 minutes that you have reflect the work done with Maryland Department of Health to ensure that the bill has that it is reflective of the regulations, I should say. As I mentioned, I did have a chance, we know a question came up regarding HSCRC, who have been wonderful in talking with me about the bill. Since then, I'll let them speak for themselves, but they're very supportive of the bill. And the only reason that I am neutral on the amendment is just because I have not had the opportunity to talk it through with the doulas. But I think that if the committee is comfortable with it and wants to move forward with it, then I am fully supportive of it. So I have talked to various stakeholders since our meeting, and I have no objections to the amendments and suggestions that I am aware of, where I know other folks will speak up about them. Thank you so much.
Thank you for being with us today. So I will call on, I guess, Pam Case-Meyer, then Megan, then Mr. Tiffin.
Thank you, and members of the committee, subcommittee. I'm here on behalf of the American College of Obstetricians and Gynecologists and MedChi. Last year, you had legislation that we actually were opposed to because of a number of provisions. We're super supportive of doulas. They're a critical component, but we thought that the provisions in the bill last year had some unintended consequences. As a result of that, there was a stakeholder meeting put together, a work group of all of the interested parties. We worked through the interim, developed a fabulous regulatory structure that virtually everyone was in agreement. It was the consensus framework. And as Delegate Wilkins said, this bill mirrors that regulatory framework. The regulations were published in the fall. They've been finalized. There was no detractions. The amendments that both Ms. Hopwood referenced and submitted by the HSCRC are just putting them in line with that. The one from HSCRC, as I heard it, really is just reaffirming and clarifying. It's our position that they're not going to have any impact on the hospital rates to begin with. We're fine with clarifying that that won't be the case because the way their services are provided, it's really not, they're not through the hospital. So with that, we thank everyone for working together because we think they'll be a critical component of the delivery system and think the provisions of the bill reflect the unanimous consensus of the stakeholders.
Thank you, Megan Renfrew and Scott Tippin.
Thank you, Chair and subcommittee members. I'm Megan Renfrew. I'm the Associate Director of External Affairs from the Health Services Cost Review Commission. HSCRC has made a financial commitment to maternal and child health. We're providing $40 million to the department for programs focused on maternal and child health, which is a state health priority. And that includes funding for Medicaid's doula program. So we are committed to the idea of Medicaid supporting doulas so that the doulas can support women who need that support. HSCRC sets all payer rates for hospital services in the state. We do not set rates for non-medical services or for professional services where the professional bills themselves. HSCRC expects that most doula services will not fall under HSCRC's regulation related to rate setting, but to the extent there might be a small chance that hospitals would employ doulas who didn't bill independently, our staff were concerned that the language in this bill could interfere with our all-payer rate setting. The solution to that would be to make sure that this doesn't supersede HSC's authority to set rates for hospitals. HSCRC rates would apply to what the hospital is paid, not to what the doula is paid. Again, in this likely rare situation in which hospitals would be employing doulas who didn't bill, the hospitals and the doulas would decide how the doulas were paid under their employment agreements. We have had similar language in other bills. There's an example last year in the telehealth bill that passed. It's almost identical language that I proposed here. And I agree with Pam that this is just reaffirming and clarifying our authority as a commissioner on hospital rate setting. So thank you.
Are there any questions for Megan from the committee before I go to Mr. Tippin? Okay, Delegate Wilkins.
Oh, hi, Madam Chair. Did you want me to respond to that? I'm sorry.
Yeah, do you have anything to say before I move on to the next person?
Yes, I really want to thank HSCRC for meeting with me today and walking me through this. I'm totally fine with the amendment and the suggestion, and just grateful for their work with me and on this issue.
Thank you, Delegate Wilkins, for working with everyone. We appreciate you. Next, Mr. Scott Tippin.
Thank you, Madam Chair. My name is Scott Tiffin. I'm here with the American Academy of Nurse Midwives. We just had two very small language questions that we just kind of wanted to flag. At the hearing, there were a lot of questions about the role of doulas and what medically necessary meant in the context of doulas. And our nurse midwives are very, very, very supportive of doulas. We just wanted to make sure it's clear their role and that they're clearly kind of being fit into the team, the medical team. And so the two questions we had, one was for the definition of doula services. And our suggestion was to add a word saying non-clinical. So it'd say doula services means non-clinical, continuous physical, emotional than the rest of the definition, just to clarify and assuage any doubt that these are providing clinical services. You know, as we all know, I think on this call, the doulas are providing support services and things like that, not actually clinical services. And then the second piece of language that we kind of wanted to throw out there is on page 4, line 7, where it says the program has to reimburse medically necessary services. We wanted to clarify that services that are referred for by a licensed healthcare provider or a certified healthcare provider are medically necessary. So the language we were proposing is medically necessary as determined by a licensed or certified health practitioner in line with requirements set by the department. So we just felt that both of those amendments just really clarified the role and kind of would assuage any questions folks had about how this is supposed to work.
And I think that's great because there were some questions about that and we wanted to make sure that was clear. So thank you so much. Any other questions regarding this bill or the amendments? I have Delegate Hill, followed by Delegate Shalega.
So like the bill, I think Mr. Tiffin raised to a great deal my issues with the bill in terms of medically necessary. And I think the clinical part up front is helpful. I'm a little concerned still about that final page. And so as I understand it, his amendment would be first on page 2, line 25, number 7, medically necessary. I mean, this is what it says. Medically necessary means that a service of benefit is directly related to diagnostic, preventive, curative, palliative, rehabilitative, and militative treatment, which is not what doulas are supportive of that, but that's not it. So I guess it's for Aaron. Do we need to, if we're going to try and keep clear that this is not a medical service doulas provide in support of medically necessary services, do we need to do something on page 2? Lines 25 through 29, and it's really line 25.
Just give her a second to review it, okay? Thank you. While I do that, Mr. Tiffin, do you have a question or is your hand up from the last question?
It was still up. I'll put it down.
Thank you. It just keeps me straight.
And well, if I may, Madam Chair.
Hold on a second.
Okay, it's
Delegate Hill.
All right.
I just said really smart stuff and I was muted and I didn't realize.
Well, unfortunately, because it comes naturally,
It goes
you'll be able
without
to say
saying.
smart stuff again.
Can you just trust me? So so you're saying that a doula does not provide
Medically necessary care. We provide
right.
support
I mean,
care.
it says directly related to diagnose, it's not saying that they diagnose.
They don't. And in fact, if you look at
I
their
think if you
definition,
add that extra,
I think it's the necessary that's the problem. So even
Yeah,
if
it's a
you
good
add,
point.
even with Scott's suggestion of saying clinically indicated, but medically necessary is a problem throughout this bill. And then when we go back into 7, page 5, line 7 and 8, a managed care organization that participates in the program shall provide medically necessary doula services. They're not medically necessary. They may be medically indicated. They may be medical, as he said, medically ordered or directed.
Yeah, I
or
think if you add that,
requested,
Delegate
but-
Hill, let's see what Erin has to say.
maybe if you add that extra as directed by, I think what you all need to be very careful with here though, is that these are codifying regs. So if the law gets too off base from the regs, just to be mindful of that.
But I think the other problem is that it becomes hard to justify Medicaid reimbursement if it's not medically necessary.
Right, and that's what they're
saying.
saying. That's what they're saying.
And that's the needle that has to be threaded, and I don't think we've done it.
Mr. Tiffin, do you want to reply to?
I was just going to add one thing that maybe is helpful. As we understand it, is that the services have to be medically necessary in order to get CMS reimbursement. And our understanding is that, or what we would like to see is that medically necessary, meaning it was ordered by a provider. And that is how we kind of imagine this working. But the medically necessary is important for CMS reimbursement, is my understanding. But we did run these amendments by Maryland Medicaid, and at least the 2 that we proposed, they don't think will mess up their regs in any way.
Okay, I think that's important to know.
And Madam Chair, if I may point something out.
Mm-hmm.
If a physician writes an order that someone needs, I don't know, a diaper, it becomes medically necessary. because they've ordered it, right? So all the stuff you have in here that would make medically necessary apply to nursing care, physician, whatever. It's not the same in us trying to squeeze it in there without being clear that this is directed by a medical provider, it's ordered by, is where our problem is.
So I think Mr. Tiffin's amendments do that.
Not, but you gotta, well, we can talk.
You might
about
be okay with the medically necessary because of the directly related language. It doesn't say that the doula.
Maybe can we see them in an interlineated?
It's in the bill. If you pull up the bill.
I mean, Scott's.
Oh, Scott. So I'm just hearing these.
Right. So, I mean, Madam Chair, what I'm saying.
So are we going to do Delegate Hill? I'm going to
hold
discuss it, but we're going to hold it so you can look at the language, make sure that everyone is comfortable. There's no need to rush it. We have time. Okay. And make sure that we are, because part of the reason why we're here with these is because we heard, some feedback and they were incorporated in the amendment just during the hearing. So let's have the discussion, but we'll hold it and make sure that it's sent clean and you're all comfortable, okay?
I mean, I'd like to move all of the amendments one at a time or collectively, but as long
we're
as
going to hold it so you'll have a chance to review it.
Okay.
And not only do you have a chance to review it, you can also work with the sponsor and with Mr. Tiffin. I would advise you to do that and would invite you to, and make sure that the language is comfortable, okay?
As we have.
I value your experience. Thank you. Delegate Shalega.
Thank you. And thanks for bringing this bill, Delegate Wilkins. I have a number of friends who were doulas, and it's just wonderful to see us moving this direction. I do have a question. Let me get to my notes here. I had talked during the bill hearing about some kind of conscious clause or conscious protection. And then Pam Casemeyer pointed out that Health 2214 says a person may not be required to perform an abortion. And I would say the doula is assisting the woman and not performing the abortion. So I'd like us to consider some kind of protection there. Two of my friends that are doulas work for an agency. And so, they would want the protection to say, if you're sending a doula out for abortion services, they want the protection to not to say, no, I'm, conscience clause says that, I can't go on an abortion case.
The law, if I may, go ahead, Erin.
No, you got it.
Say the law, but that's already the law, but go ahead.
That section also says that a person may not be required to participate in an abortion. So it's not just provide, it's also participate in.
So the section has both for the person who provides and the one that participates to be able to use the law to, not have to do it. It's in the law.
Yeah, if you can send me that, I would appreciate that, having that, for my records as well.
Absolutely.
Okay.
We'll do that.
I think Maryland Right to Life had a question, concern of, let me look at theirs. If anybody else has a question, go ahead of me and I'll pull that up real quickly.
Yeah. Erin, will you be so kind and send that section of the law that applies
I'll
that
do
we
it right
discussed last week to not only Shalega, but to the whole committee?
Sure.
Thank you so much. Any other questions? Any other questions? I don't see any for now. So Delegate Shalega, I go back to you.
Yeah, that's fine. Since we're holding it to look at it, I'll look that up. And if I have any questions, I'll talk to Delegate Wilkins and
That'll
to
be great
about it. Thank you.
Thank you. Thank you. I appreciate you. Delegate Riley. You're muted.
Thank you, Madam Chair. Sorry.
My pleasure.
Just to follow up on Delegate Shalega's question, I think I wrote down in my notes something, I believe it was her or Delegate Kipke during the hearing, asked that, we know that there are doulas that do assist in abortions, and they're called abortion doulas. But they don't, if it wasn't the doula was not there for that purpose, okay, because they would know ahead of time, obviously, and that's where we say they can not go if they don't want or not do the doula, do the job. But the doulas don't perform the abortions. They cannot by current law. And the doulas cannot even prescribe any type of medication. I think the Maryland Ray for Life was worried about the doulas prescribing medication to cause the abortion. Is that they cannot do that? Am I clear on that?
They don't prescribe.
They cannot prescribe any
That's
kind
right.
of prescription
That's
or
right.
any. Okay. All right. Thank you.
My pleasure. Good question. Any other questions or concerns? Okay, so we're gonna hold the bill. Delegate Wilkins, I hate to give you homework, but I need you to work with Delegate Hill and Mr. Tiffin on that language, and with Erin. And then if you can make yourself available for Delegate Shalega, if she has any questions, that would be great. Delegate Hill, I thank you ahead of time for working with them. And thank you all for being patient as we discuss this bill today. So we're gonna hold it. Thank you very much, Delegate Wilkins. We have now House Bill 578. Erin, will you be so kind and take your time?
That's fine. This bill prohibits Medicaid and the Maryland Children's Health Program from applying a prior authorization requirement for a prescription drug when used for the treatment of an opioid use disorder, and that contains methadone, buprenorphine, or naltrexone.
And that is Delegate Kaiser. Delegate Kaiser.
Well, thank you, Madam Chair. I think Ann Seacott is here and she could probably say anything better and smarter than I could about the legislation. So glad to pass the baton.
Not a problem. Ann, good evening, Ann. How are you?
I'm well. I hope everybody's doing great on this Monday night. The short of it is the bill would prohibit prior authorizations for medications used in the treatment of opioid use disorders. The General Assembly passed legislation creating that prohibition in the commercial insurance market a few years ago, and this would apply that prohibition to the to Medicaid as well, creating some equity there.
I know there were some questions when we were here, and I wanted the department to come to talk to us. Are they here? I know they were supposed to be here.
Delegate Pena-Melnick.
Hey, Tricia, how are you?
I'm here, and so is Athos Alexandra.
Okay, great. Haven't seen you in a while. Thank you for being with us. We really appreciate you guys. So can you talk to us, please?
Yeah, so Athos chime in as well, but it does have a fiscal impact to us. So as you all know, we operate a preferred drug list in the Maryland Medicaid program. And as part of the negotiation with drug manufacturers, in particular for Suboxone, the brand name drugs, manufacturers give us an additional rebate in order to not have authorizations and to be on a preferred drug list. So what this means, we get quite a bit of money from these negotiations. We can't give you the absolute specifics, but it's millions and millions of dollars in terms of what comes into the state for these drugs to be on the preferred drug list in exchange for not having authorizations attached to it. The generics do have authorizations as well.
Great. And does anyone else want to be heard from your department, Tricia?
Athos, did I explain it correctly?
Absolutely, Tricia. Thank you. Thank you, Delegate Pena-Melnick. Good evening, everyone. Athos Alexandru, the Director of the Office of Pharmacy Services from the Maryland Department of Health. Thank you for having us tonight. But Tricia is absolutely correct. When it comes to some of those products, drug manufacturers, because they would like to get, I guess, their product preferred without prior authorization, they're willing to give us significant, and when I say significant, I really mean it, rebates in terms of the net cost to the department for some of their products. and that is the case with the branded product of what is known as Suboxone, whereas the Suboxone film, whereas the generic equivalent products, unfortunately, they are there is no incentive for them because they are generics. There's no incentive for them to give us any discounts, and therefore, like Tricia said, we're talking about millions and millions of dollars in savings by making the brand preferred over the its generic equivalent. There is also another set of drugs that we do put prior authorizations. Those are usually the injectables, and the reason why we have a prior authorization on them is because it's clinically. We want to make sure that the drug is dispensed when clinically appropriate. I'm not a clinician, by the way, so I will not be able to engage into all the details. But the FDA, the Food and Drug Administration, when they approve these products, they put some in the products labeling. They put some stipulations, and that is the reason why we have a couple of those branded products requiring prior authorization to make sure, because they're injectables. We don't want to inject a patient and then have severe withdrawal symptoms and with no recourse. And that's why we may have them, the prescriber to attest in some kind of trial of an oral product first, which it's easily reversible versus a long-acting injection. And that's basically the reason why we have these prior authorizations.
I guess my question is, before I get to Ann, is that we know that the numbers have gone up, right, of people that have overdosed and died in Maryland. Like, we're number 7 in the country with the highest number. I know that the private insurance, we got rid of it. We put in a bill to get rid of it, and they seem to have been, doing fine. So my question is, knowing that you do have this rebate program and you do get millions, is there a way that we can try to do this? Can you think of a way where we can eliminate these barriers? Because that's what we have, is the barriers, to access to care. I know of someone that there was on a Friday, she got the prescription and they needed the prescription to be filled, and because there was prior authorization needed, she couldn't get it on Friday. Over the weekend, she died. Okay, so is there a way that we can try to work, or can you think of a way that we can amend the bill to address some of your concerns? And I can't thank you enough, both of you, because I know you're busy, for coming to meet with us on a Monday night. I mean, we don't take it for granted. While you think about that, because I just put you on the spot, and I apologize for doing that. I don't like doing that. Let me allow N. Kaiser, Delegate Kaiser, to speak, and then N. Seacock, and anyone else from the committee that wants to be heard. Delegate Kaiser.
Madam Chair, I just want to thank you for, since this was originally your bill 5 years ago, and how you really helped make the argument just now in asking for an amendment from the Department of Health, because the point is that we are trying to provide services and we are trying to help people in dire situations. So I do know that Ann Seacott's going to mention the amendment. She had asked me who was going to mention it, but I did want to step in and make the other point that that this bill is designed to give people quicker service than they are currently getting. And again, anything we can do to make that happen is what we should be doing. Thank you.
Thank you. And Sika.
Thank you, Madam Chair. Also having talked about this across the street as well, there's been an amendment drafted that would apply the prohibition of the prior authorization to only the brand name drugs. And that would, I think, at least to one of the points that Ms. Roddy, Mr. Alexandra said had mentioned, should, I think, address a large part of the concern around the fiscal note. Our intent is not to skyrocket, not prices, but the state expenditures on this. We want to make sure people get access. So I think that part of what we had talked about at the hearing was also kind of trying to codify some of the existing practice so that there isn't switching of medications on and off the preferred drug list, which hasn't happened often, but has happened and has caused significant problems for people receiving treatment. So that's something that's I think been drafted, and I think Delegate Kaiser, as the sponsor, is comfortable with that.
So, Tricia or Mr. Athos, what do you think?
So unfortunately, it still doesn't solve the fiscal problem, because if you're guaranteeing that the brand name drugs don't have authorization, the companies have nothing to negotiate. There's no leverage for us to negotiate with them. It's just it's just how the negotiations work. So what they give to us is money in exchange for not having authorizations. So the amendment, what you're proposing, just simply guarantees that they won't have authorization. So it takes that leverage that we have, or that key, that nugget that incentivizes them to give us, again, millions of dollars in rebates. I guess, what I would say is that, the ones that are on the preferred drug list have no authorizations. So there are a set of drugs that are on the preferred drug list that, again, don't have any authorizations or barriers in order to get access to those drugs.
Okay, we have Delegate Hill followed by Delegate Bagnall. Thank you, Tricia.
Thank you. Ms. Roddy, you're talking about these rebates. Is what arrangement you have with the brand manufacturers different from a subscription model like we've seen people use with hepatitis? And if so, can't we switch to a subscription model where they give us X number of doses at a fixed price because we're guaranteeing those doses? Then you don't have to do pre-authorization either as a incentive or as a practice?
So I think the subscription model worked with, sort of the high volume drugs. It worked for a point in time for those states around Hep C. I would think if you went back and asked them, today, whether they saved money on those, I think the states would say that they didn't. So I think those are complicated negotiations that really need, some actuarial analysis attached to it. I don't think it would have the savings that we're talking about here, that we are in terms of how the preferred drug list works.
All right, then if I may follow up. So I understand from what you're saying is you're using pre-authorization to force a generically written prescription to be rewritten as brand. And that's a delay, right? So somebody writes a prescription for the generic, they go through pre-authorization there. So no, you got to use something on the list, and the ones that are on the list are the brand.
The ones that, again, they have negotiated with us, and it happens to be the brand name drugs, and in exchange for no authorization, they are giving us substantial rebates.
Right. So from the practitioner standpoint, you have made a deal with the manufacturers to do the exact opposite of what practitioners are trained to do, which is to assume the brand is less expensive. And I mean, the generic is less expensive and right for the generic. So what education are you doing to the practitioners so they know for these 3 drugs, you need to write a brand name because it's going to be cheaper for you. And saying you put it on the formulary on a certain tier, that no one's looking at your tiers, right? The providers aren't looking at that until we're forced to do pre-authorization. So since it's reverse of what most practitioners are doing, why aren't you just telling them that?
Well, I'll let Athos speak to the specifics, but if we're not getting that message out, that's definitely something we can work on as a department.
Thank you, Tricia. So Delegate Hill, just for the record, I believe Suboxone, the branded product, is being preferred for at least the last, I want to say 4 or 5 years. So practitioners by now, they're well aware of the difference between the generic versus the branded and what we cover, number one. Number two, our preferred drug list is posted on our website and also through what is known as the Formulary Navigator, which practitioners have easy access from at any point in time through their desktop, mobile phone, or any other tablets or whatever other electronic devices they may be using. And lastly, what I want to say is that we have actually done a lot of outreach to pharmacy providers so that pharmacy providers, when they have a prescription for the generic, they do know to reach out to the prescriber, and basically this prescriber, all it will tell them is that that's fine, just change the prescription to whatever Medicaid covers. The last thing I wanted to say is that in any given year, we have about 300,000 prescriptions for the branded product, and maybe 15 to 20,000 prescriptions at best of the, actually not even that, it's about 5,000 prescriptions of the brand of the generic product. So you can see that, 5,000 versus 300,000, it seems like, the prescribers or the practitioners, are getting the message, and they've been getting it for at least the last 4 or 5 years.
So, okay, so I have a suggestion, but to your point, the 5,000, we wouldn't be doing this bill if it wasn't for the fact that you're getting stuff that has to be pre-authorized and switched to the other. So
we do
5 years, there's still 5,000 prescriptions being written where people are doing what they normally do, which is right, which is supposed to be the cheapest, which is generic, right? So whatever the outreach is, it's not good enough, and because nobody reads the formularies. So the question is, we have a law that says if a prescription is written on other drugs and the prescriber does not specify brand necessary, that the pharmacist is required to fill it generically. Can we do something, or how would it affect us if we put a law in for this class of drugs, unless the prescriber says must be administered in generic form, that the pharmacist must do the reverse of what we do in the others, so it doesn't have to go through pre-authorization. The pharmacist is required to issue it as a brand necessary for this group of insured. So we can tell them that they have to do it brand. Will that solve the problem? So if it's Medicaid and it's written generic, they can have a rule that says you got to fill this brand unless the doctor specifically says, I do not want brand, just like they do the opposite now.
So I guess, it's all part of the negotiations. So if you've pretty much, again, it goes back to if you're guaranteeing that the brands don't have any authorizations, there's no reason to give us millions of dollars.
So the 300,000 that are going brand without pre-authorization versus the small puny 5,000 people who aren't getting their drugs in a timely fashion, those numbers don't work for your negotiation issue the way they work for Mr. Athos talking about why this is fine.
So what I want to do, I want to stop us here, and I know Delegate, I know you had a question, but I'm going to stop us because we have 2 more bills, okay? And it's 7:40. So this is what I want to do. I want the department to work with the sponsor, Delegate Kaiser, and Dr. Hill and NCCA, and see if, I'm going to bring it back next Monday, and see if there's something that can be done. And you have a week, because we're putting you on the spot, and you came to tell us about rebates, and we're grateful. So if you could please make yourself available, and Delegate Kaiser, will you reach out to Ms. Roddy, please? and get in touch with her office. And you know how to reach Tricia. We all do. If you could do that and meet and try to work on it, I appreciate it. Delegate Bagnell, quickly, is there something you want to tell them so they consider while they're working on it?
Thank you, Madam Chair. And actually it's following in the lines of Dr. Hill's thinking. I understand that, you know, it impacts the negotiations if we say that they have to automatically sort of up to the name brand, but could we have a trigger where they could, they would have to go by the preferred? Would that still impact the negotiations? Because the negotiations seem to be about getting on that preferred list. So if we had a trigger whereby they could, they would automatically have to go to the preferred list, would that solve the problem? Just putting
And that's food for thought, so they can have it in their, hopefully, toolbox and think about it, okay? So next week, we will be so grateful if you could be with us again at 6 o'clock, and we'll try to, you know, put you towards the front, okay? Because we have already discussed this for a while, but if you can come up with some solutions, I will be very grateful, okay? And thank you so much for being with us. We appreciate you, and you're welcome anytime into our committee. So next we have the following bill. We're going to do House Bill 96 and the last bill 275, okay? House Bill 96 is Public Health Non-Discrimination and Access to Anatomical Gifts and Organ Transplantation Financial Status. Erin.
This bill prohibits discrimination against a potential recipient of any anatomical gift or organ transplant solely based on an individual's financial status, in addition to existing provisions under statute.
Earlier, I talked to many of you in anticipation of these bills, and I had a conference call with Emily, Delegate Shetty, and with Kristen Bryce as well. So if you can tell the committee what we decided to do, and who would like to go first? Delegate Shetty, followed by Kristen.
Sure. Thank you, Madam Chair, and thank you, colleagues, again, for indulging me on this second bill this evening. So the initial draft of the bill was exactly as Ms. Hopwood described, and the purpose of it, the intent of it, is to prohibit transplant centers here in Maryland from using a patient's financial means as a way to remove them from an organ transplant list, or from performing an organ transplant surgery in the event that, for example, a kidney donor volunteers and is a match for a friend to be a living organ donor, that patient would not be prohibited from receiving the very generous donation based solely on their financial needs. So the amendments that we discussed, and I've worked very, very closely with, and I'm very grateful for the continued collaboration from our hospitals, from Johns Hopkins and as well, to address any concerns that they had related to this bill. Several amendments have been drafted. One big sponsor amendment is in the process of being drafted that seeks to address some very valid concerns over the initial construction of the bill. What we did initially when drafting it was I kind of sloppily suggested to DLS that I wanted a bill that essentially inserted financial status in the same section as the disability prohibition that was enacted in 2015. I think Delegate Hill was the leader on that effort a few years back. By doing that, I unintentionally created a cause of action that was under the ADA that was not intentional. And so we worked closely with Ms. Hopwood to redraft the text of the bill so that disability has its own section. And then we would have the financial status section be within the same section of code, but its own language. And it includes many of the same provisions and prohibitions, while also seeking to include some of the same things that our social workers who work very hard with patients in our transplant centers currently do. We didn't want to unintentionally prohibit it, which is they do use information around the support network that families have at home to direct appropriate supports where needed. So I didn't want to unintentionally prohibit them from using financial information as a way to direct support to them if they needed additional care post-transplant or during transplant. There remain some additional concerns that I'm trying to work out with the hospitals, some of which might have to be done during the interim around insurance coverage, which is much more of a holistic issue that is primarily a challenge in my view of and I think from the conversations, as I understand it, of patients who are underinsured who might have high deductible health plans that are regulated by the state. But when they come in for the transplant, they don't have the money to hit their deductible. And so they're insured, and the treatment, the surgery is medically required and would be covered, but for the patient's inability to meet the deductible. And so, so we're trying to figure out ways that we can more holistically address some of these challenges. And then of course, there is the need to ensure that post-transplant patients are able to access the therapies that they require, which can be expensive. And so I think what other states have required, which we don't want to do here in Maryland, is a patient to show access to liquid funds in order to cover the cost of immunosuppressant therapy. That is not the way that I think we should go as a state. And so it's actually the initial idea for the bill was to ensure that these decisions are medically based, not based on a patient's financial status. And then I've spoken with the hospitals as well about some additional amendments that they'd like to see. I need to confirm that those amendments don't put our organ transplant program here in Maryland in jeopardy unintentionally. And then I'm continue to remain open to their thoughts and suggestions, as well as to the committees on how we can improve this effort. Thank you.
Thank you so much for all your efforts, and thank you for meeting with everyone. In ACO, that's how we like to do it. So we really appreciate it. Kristen Bryce.
Thank you. Thank you, Madam Chair, members of the committee, for your indulgence. I know it's getting late, and I want to thank you for your availability this afternoon. I want to thank Delegate Chetty for her ongoing availability. We have met on a number of occasions, and I'm not sure I can do a much better job of outlining some of the issues than what she just did herself. So I'll try to be somewhat brief. Just wanting the committee to appreciate the complexity of these cases and have an appreciation, I think, as we've all developed over the course of time talking to our transplant teams, all of the costs that are involved with transplant, and Delegate Chetty went through some of them that are very significant, like the cost of anti-rejection drugs that are really about insurance. They aren't hospital costs, but they can run in the thousands of dollars every month post-transplant for these patients. There are deductibles and co-pays and co-insurance and sometimes lifetime maximums around insurance coverage that present obstacles to these patients. And there's a lot of financial counseling as well as psychosocial counseling that goes into making sure that patients are as transplant ready as they can be, because this is a lifelong process for patients. So you think about identifying all of those gaps in potential cost coverage for patients, and then how do they address those? And so our social work teams and financial coordinators work with patients to try to address the gaps in coverage that we know they're going to face going forward, whether it's prescription drug costs or transportation costs. And there are other, there are resources available, whether it's through nonprofits or Social Security benefits, sometimes the VA, their prescription drug assistance programs. But, some of these costs just aren't addressed by the legislation itself. And I understand that maybe on this first pass, we aren't going to get to all of those things. I do also very much appreciate Delegate Chetty's concern about programs around the country that she's heard of that may require some demonstration of liquid assets before transplant would be approved. We don't think that is an appropriate policy. It's not something we do at UMS, and I don't want to speak for Hopkins, but I'm looking at Elizabeth Hafey, and I know it's something that they don't do in their transplant program either. We do still have some concerns, and to Delegate Shetty's point, we've continued to discuss those. So for instance, our programs aren't participating providers with every state's Medicaid program. And so if that's the case, it just wanted to make sure that that wouldn't be viewed as denial of care based on financial status. So, you know, there are some technical issues like that that we continue to look at. Delora Sanchez, I know, is on the call and has kind of been keeping a running list of some of the other issues that we want to continue to talk about. But I just appreciate this opportunity to air this with all of you. And because of the late hour, I will stop. I don't know if there are others you want to have comment on this. So thank you, Madam Vice Chair.
Yes, my pleasure. Thank you, Delora.
Thank you, Madam Vice Chair and members of the subcommittee for allowing me to speak on House Bill 96. And thank you to Delegate Shetty. You really have been very accessible and very helpful as we're working through this. Have an open door policy to a lot of our concerns. And as Kristen mentioned, we did take a look at the initial amendment, the initial sponsor amendment. We think there's some refining that can happen there. Again, as Kristen kind of laid out, there are lots of just different considerations that go into the transplant process. And ultimately, we want to see if we can get some additional guardrails that will allow the two centers at University of Maryland and at Johns Hopkins to continue to provide transplant care. But I think even more importantly, ensuring that those that do receive those transplants have those services following, non-hospital services following the transplant that will allow them not to reject any organs that they receive. So we have been communicating with Delegate Shetty. We would like a little bit more time to flesh through the sponsors amendment, refine it a bit, and certainly look at a few more that we have been discussing. We think that we can get there on this bill, but we do need a little bit of time to refine some things.
Wonderful. So Delegate Hill, we're now going to, because of the late hours, get into it because they're still working on it. I just wanted them to come to the committee and give us an update. They're going to go and meet, work it out, and perhaps your concerns are addressed, but they're going to do that. I want to give them the time because they're at the table to go ahead and do that. I just didn't want you to wonder where's the bill. So that's the update. Okay, thank you for being flexible with me tonight. So thank you so much for being with us, and then let us know when you want the bill back. We meet every Monday at 6 o'clock, and you can communicate with Aaron, okay, as well. And thank you so much.
Thank you.
My pleasure. And thank you all for, for being at the table. Thanks so much, and for the work you do. We appreciate you. So we have our pleasure. The last bill for tonight is House Bill 275. And we're not voting on this bill tonight. We, over the weekend, on Saturday, Sunday, today, I spoke to a lot of different people from the industry, from the advocates to the sponsor, you name it. So I have given them some direction, and I want to just go ahead and start the conversation with this bill. Aaron, can you tell us what the bill does, the way it's in front of us?
Yes,
then I'm going to let the sponsor address us, and then some of the representatives of the industry and the advocates. But we're not voting on it tonight, okay? I have urged them to work together to try to compromise on the language and see if they can come back to us. So Erin.
The bill would establish and expand several prohibitions and requirements that relate to the manufacture, sale, and distribution for sale or use in the state of specified products that contain intentionally added PFAS chemicals. I didn't include any of the amendments that were proposed in the amendment packet, just because tonight's purpose was to discuss the bill with stakeholders.
Yep. Thank you so much, Erin. I appreciate it. Delegate Love.
Yes, and one order of food to pick up.
Well, Delegate Rosenberg, since we heard you, you have to order for everyone. Do you want our addresses? Go ahead. Delegate Love, go ahead.
Thank you,
I'm
Madam
sorry.
Chair, and colleagues, thank you so much for your time this evening. I've actually really enjoyed listening to your subcommittee. I love how you work. It's fantastic. So this bill, as you've heard, has some amendments. I have been working very hard listening to the opponents and trying to find some areas where we can work together. So the overview is that this bill would ban the use of PFAS in firefighting foam. It would require notification of when there's PFAS in firefighting gear, and it would ban the use of PFAS in food packaging and rugs and carpets. I sent to you a little while ago some amendments that address a number of the retailers' concerns as they were conveyed to me, that only manufacturers, not distributors, should have to create and submit the certificate of compliance, that someone would have to knowingly sell or offer for sale a product with PFAS. I understand there's also a concern about the definition of manufacturer, which I am absolutely happy to work with the retailers on, because I understand their concern there and happy to work on that. I also pushed back the date of compliance because all of the other states that adopted either a firefighting foam ban or a food packaging ban, the average was about 2 years. Most of them had 2 years. One had about 1.5. I think one had 3, but the vast majority was 2 years. So I pushed back the implementation date. I also, in listening to some of the concerns from the gentleman from the Foam Coalition and from ACC as represented by Nick Manis, I see him here, am willing to put forth some language regarding terminals and the port and align our dates with the Department of Defense. And dates with some other states that relate to that. And then last but not least, the elephant in the room, and that is the definition. There has been a lot of concern about this definition. And I will tell you that I have done a lot of work, and the firefighters and the environmental groups have done a lot of work, and the definition is actually very important. And some of the offered other definitions, and I want to thank Delegate Riley for providing me with her amendment. I truly appreciate that. Some of the problems with that, and we have Jeff Buttle, who can talk about it from the firefighters' perspective, but that will severely hamper their ability to keep themselves healthy with their firefighting gear in the future. It also will substantially limit the bill as it applies to firefighting foam. We have a number of other states that have this exact same definition in their bill. And then we also have several states that have this exact same definition and also add limiting language for purposes of firefighting agents and firefighting equipment, for purposes of food packaging and rugs and carpets. And I am absolutely willing to add that language to address W.L. Gore's concern about the overbreadth. They did acknowledge that this bill does not apply to them as written, but hearing their concern about the slippery slope, I'm absolutely willing to add that limiting language. So with that, thank you all for the opportunity to talk with you this evening.
Thank you, Delegate Love. So from our invites here, our guest, can you raise your hand and tell me who wants to be heard? Okay, I'm going to look at the participant. It will make it easier for me. And if you will be so kind and go to reaction, and where it says raise hand, raise your hand, please. And I will call you in the order in which I see you. And thank you for being with us. So I want to ask our guests first, and then I'm going to ask the delegates, okay? So we're going to have Ms. Lackler, followed by Jeff. Go ahead.
Thank you, Madam Chair, and good evening, everybody. I will try to be brief. And to the sponsor, thank you so much for continuing to work with us and trying to resolve some of these significant issues for us in this bill. So if we can just divide away the fire foam issue, I just want to focus on pages 6, 7, and 8 with the committee. So both in reference to the sale of carpet as well as food packaging. When our legislative committee came back and looked at the bill, we realized that anyone who is a private label, what would be considered manufacturer under this bill, gets caught in it. So just to kind of walk through this a little bit, and this is on page 7 and it starts in line 10 is the definition of manufacturer. We'd really like to see this significantly narrowed to just a manufacturer who's actually the producer of the product. Because right now it says that a manufacturer, in fact, includes any person that sells a package or packaging component to a distributor. And a packaging component, as you walk down on page 20 or on line 21, means an individual who assembled part of a package. So for instance, when you walk into a grocery store and you go to the meat section and you select a piece of meat or a piece of, say, salmon, there are packaging components that we're going to put together. And we do put a label on it, and that's also captured in this manufacturer definition. So for our private label guys, who use third parties to purchase these packaging components, they don't know what is being intentionally added or added into packaging, period. So if we can narrow this definition to just the producer, and that's the manufacturer, that gets my private label guys out of it. The second area that's been a concern, and I know Delegate Love and I were trying to work on this, and we added the word knowingly. We keep going back to the fact that whether it's a distributor, and in the bill, a distributor means any person that sells a packaged product to a retailer, so that's someone who's turning around and selling it, they didn't manufacture the product. All they know is that it's being either legally imported into the United States, or they're selling something made in the United States. And that's the end of the story. They didn't manufacture it. So our concern continues to be that our distributors or sellers that get caught in those definitions are going to be held to the standards in this bill, which there's no warning, by the way. So for a first violation, it's a civil penalty not exceeding $500. And then the second violation is $1,000. That's a pretty significant fine for someone who truly doesn't know if PFAS or PFOS was added to a component of packaging or even the item itself. So those are, I think that's a good summary of our issues. And again, glad to continue to work with the sponsor of the bill, but if we can narrow this to manufacturer, that's going to significantly help our members.
Okay, thank you. Next, I am going to call on Jeff.
Good evening, Madam Chair. I just wanted to briefly talk on two issues that are of importance to the firefighters. First of all, and it has to do with the definition of PFAS and how that has an effect on the foam portion and the firefighting gear portion, that impact the health and safety of our members. If we were to, the current definition is the preferred definition. If we accept the one, I believe that Delegate Riley is offering, perhaps on an amendment, the issue becomes that it wouldn't cover all of the AFFF foam products that are out there on the market. Currently, if we changed it to the language that was proposed, many of the manufacturers have already shifted away from that. But there would be some of the AFFF foams under the new proposed definition that would still be allowed to be out there on the market. And for the municipal firefighters, that's a big piece of this bill that we're trying to, get the protections under law for our members. Secondly, as it pertains to our firefighting gear, the requirement in this bill is just simply a labeling requirement for now. We haven't fully developed the technology to be able to switch all of our gear components over to PFAS free, but we believe that that is coming soon. And we don't want to limit our ability to be able to ban the PFAS products under the definition that was offered in the original legislation. When the technology is available in the future, we want to make sure that we're making our gear from PFAS-free materials. It's ironic that the very protective gear that we've been issued over all these years that were designed to protect us are actually part of the issue that's making us sick. So part of it is the foam piece with the definition. The other part is in the future with our gear, although that's not necessarily part of this bill because, again, it's just a labeling requirement. I think that we've figured out a few options of how to deal with these issues in working with the bill sponsor, and I'm happy to work with her and whoever else she feels as though would be helpful on making sure that we capture the intent as it pertains to our firefighters. Thank you.
Thank you so much for being with us, and thank you for the work you do. We really appreciate you in our community. Next, we have Mr. Robert Simon.
Thank you, Chair. Appreciate it. So this is Rob Simon with the American Chemistry Council. I was able to testify in the earlier hearing on this bill, but just wanted to start by saying appreciate Delegate Love's efforts to consider some of the feedback from stakeholders like ourselves. It sounds like there's been some willingness to consider some of that feedback, including as it relates to particular uses. So just two quick comments. I mean, we support the regulation of PFAS in these three product areas. So I want to emphasize that. We also support this in part because you can still import some of these products. In many cases, our members have moved away from the use of some of these materials, but it's important to note that we would like to see that appropriately defined close the door on some of those imported uses. The second issue, and Delegate Love spoke to this, we do believe that the definition is overly broad. No state has used that broad definition to restrict applications. What they've done is they've used that broad definition and then they've narrowed the applications covered. It sounds like from Delegate Love's perspective, that's some of what we're considering. Like if you can allow for the appropriate use of firefighting foam for emergency hazard situations or appropriately restricting some parts of the food packaging. Because what most states have done is when they have used that broad definition, they've then refined the restriction or the regulation of that particular product application. And that's why we were suggesting a slightly different definition, but we would defer to the committee and happy to work with the committee on that. But that definition is so broad that we have concerns, particularly as how it might apply to other applications.
Thank you. Next, I have Ms. Emily Scar.
Thank you, Madam Chair. Thank you, Madam Chair, and to Delegate Love, who've done a tremendous amount of work on this. I just wanted to touch on a couple things, although it feels like we're in a good position and I'm optimistic that we can work through and move a bill this year. First, on the retailers, it's always a really tricky needle to thread to make sure we are not putting an undue burden on the retailers while also not creating a giant loophole and exemption that could put our public health at risk. I think it's particularly important to make sure that we are, sorry about my toddler, that we are holding distributors liable and responsible for this. As you know, we cannot actually restrict out-of-state manufacturers. We can only restrict manufacturer of products within the state. So the distributors really are the highest person up the chain. We can stop this material from getting in, because I understand small mom and pops don't have the equipment to make sure that what's coming into their store. The distributors, however, do have that ability, and they've handled that on other toxic spills. On foam, I think the biggest thing is making sure our timeline works for everyone. So there are lots of countries around the world who are already using PFAS-free foams. We have an exemption in the bill that permanently exempts BWI until the federal government authorizes alternative foams. And I think the delegates working on, making sure there's plenty of time for everyone to transition away over a 2-year period. We want to avoid any permanent exemptions. And the states that do have foam bans, there are plenty who have used our definition and banned the foam across the board. And then, as I think is pretty clear, for the environmental health and public health perspective, we certainly don't want to narrow the definition, but I think the compromise that the delegate has put forth to say 4X uses that are entailed in this bill makes total sense. And I hope the committee will take a look and let us know if they have any questions. Thank you so much for your time. I know it's late.
Thank you for your advocacy. Next, I have, I already called on Mr. Simon. Is your hand up?
Sorry, Delegate, I'll take that down.
Okay, thank you. It just keeps me straight. And then I have Mike next.
Thank you, Madam Chairman. My name is Mike Ratchford. I'm with W.L. Gore and Associates. First of all, I'd like to thank Delegate Riley for offering the amendment, and I'd like to thank Delegate Love for meeting with us. It sounds like we have an opportunity to continue the dialogue here, interested in seeing the proposed amendments. So Gore is a Maryland manufacturer. We have 2,900 people in Cecil County who use a type of PFAS, a fluoropolymer polytetrafluoroethylene, to make products such as implantable medical devices, Gore-Tex membrane, and we make products that are used to make the COVID-19 vaccine. Our concern with it, and as Delegate Love noted, we don't make the products contained in the bill, but we're concerned about the precedent and overly broad definition of PFAS in Maryland could establish going forward. We argue that fluoropolymers are a distinct type of PFAS and do not pose the concerns that the type of PFAS used in firefighting foam would pose. And so, again, look forward to the opportunity to work with the delegates and see if we can come up with a good solution.
Thank you so much for your willingness and for being at the table. We appreciate your business in Maryland, and we are grateful that you're willing to work to make sure that we address this public health concern. Thank you. Next, we have, I thought I saw Nick Manis. I thought I saw your hand up.
Yes. Thank you, Madam Chair.
My pleasure.
I wasn't sure how to keep my hand up, so, but I want to thank you and also Delegate Love and members of the committee. We've had a couple meetings with Delegate Love, and I look forward to continuing to work with her and seeing the amendments that she's discussed. As stated, and we support the firemen. So we worked with the firemen, if you remember, on the training. So on banning the foam for training, and we still want that all, as Mr. Simon said, is a way to utilize it for those fires that right now it's the only thing that is known to put it out. So that's what we were looking for. As far as carpet and rug, we agree with Delegate Love that that shouldn't be allowed, and we're willing to work with her to make sure that's covered in the definition, and want to make sure she knows that. And then as far as food packaging, there again, there is a willingness to work together with her to narrow the definition that's currently in the bill to apply to those that FDA has also looked to ban. And again, we appreciate it, and hopefully we can come to a compromise, or just, again, I appreciate your willingness to hear our point of view, and look forward to working with Delegate Love and members of this subcommittee to move something forward.
Thank you. I thought I saw Delegate Love, your hand up again before we go to the committee.
That's okay, Madam Chair. Thank you so much.
Okay, my pleasure. Anyone else from our guest from the industry that wants to be heard?
Mitch Hubert
Oh,
has a question. Mitch
wonderful.
Hubert.
Mr. Huber, I don't see your hand, but I see, go ahead.
Yeah,
Wonderful.
I can't
That works
find the
too.
raise hand icon, sorry.
That's okay.
Well, I guess I just want to reemphasize the fact that there are some scenarios where there are not drop-in replacements for the fluorinated foams. And so the exemptions we were asking for are very, very specific to those specific areas where we don't have the drop-in replacements and where we probably need a little bit more time as an industry to come up with that. And keep in mind, all of the members of the Firefighting Foam Coalition make non-fluorinated foam. We'd be happy to sell you non-fluorinated foam. In fact, it would be a windfall for us, but it's just at the point where we couldn't guarantee that those replacement foams would work significantly well enough in these exemptions that we've asked for. And so we're asking for a little bit more time. We'll remind you that the European Union and New Zealand have gone with a 5-year transition period. And I would hope that we would get there even before that 5 years. But right now, if you forced everybody to shift over, there would be some of your companies who could not comply because they simply would not have the time to do the engineering, infrastructure changes, all kinds of different things that come into play. And I'd also point out, I don't know, maybe your counselor can let us know, has Maryland codified NFPA 1 as your model building code? If that's the case, you're going to wind up with some people who will be outside of the law on one side or the other.
Thank you. Anyone else from the industry? Anyone else from the advocacy community? Okay, seeing none, I'm going to the delegates now. And this is the order that I see. I see Delegate Kaiser first, followed by Delegate Bagnall. And thank you, committee, and Delegate Hill next. Thank you for your patience, okay? Delegate Kaiser.
Thank you, Madam Chair. I had a question for two different people, two different things that I thought I heard say. I heard Mr. Hubert say that there are no drop-in replacements. Now, my understanding is that this bill is only about the foam, the rugs and carpets, and the food containers. And my understanding is that each and every one of those have easy replacements. And what I did not hear Mr. Hubert say at all was any reference to any examples of which things do not have replacements. So if that's some, I don't necessarily need to hear the answer now, but if that's something you can provide, because it sounded like hyperbole without any examples. So I would love to see a list of examples if you could. And then my question for Mr. Simon.
So can we do one question at a time? So Mr. Hubert, if I may, is there a replacement for foam, rocks, and carpet and food container? I believe that's the question of the delegate. Is that your question, delegate?
Pretty much.
If you know. We can't hear you. Can you hear us?
Are you
Hubert?
asking a question of me?
Yes, the question that the delegate asked is there a replacement that she believes there's a replacement for foam, rugs, carpet, and food container, that the bill deals with those 4 items. And she believes there is a replace, they can be replaced. So
Yeah, there are certainly firefighting foams that do not contain PFAS, but they don't work as well on fuel and depth fires. So as I stated last week, for municipal fire services where they run into mostly spill type fires and can apply at very high application rates, there's no problem at all. But when you get into some very specific fires where you have fuel and depth, because the foam does not shed fuel, it's problematic. Also, there are no underwriters, laboratories, listings, or factory mutual approvals for many of the foams that are used in overhead sprinkler systems that are used to protect Class B flammable liquids. They just don't exist at this point. And so if you ask somebody to switch to a fluorine-free foam, they wouldn't be able to and still comply with the law or still keep their insurance.
Okay.
Madam Chair, my other question is also very brief for Mr. Simon. I heard him say that our definition in this bill was unlike any other state, but my understanding is that quite a few states, California, Connecticut, Colorado, Maine, Minnesota, Vermont, Illinois, Nevada, have the exact same definitions. So again, maybe it's not something you can respond to directly now, but I would like to understand why you think those definitions are different.
Sure, and I appreciate the question. I may have not been very clear, so you are absolutely right. Those states have that broad definition. What I was trying to say, and I probably didn't say it very well, is that while they have that broad definition, when they went to regulate the specific applications, they then defined those differently or further so that they would exclude certain things from that. What we were suggesting was a definition which would proactively try and address that, but you've raised a key question. So definitely other states have that broad definition, but as they've looked to regulate specific application, they've then defined it differently or more narrowly. So hopefully that helps.
All right, just glad to understand. Thank you.
Thank you, Delegate Kaiser. I have Delegate Bagnall, followed by Delegate Hill next.
Thank you, Madam Chair, and thank you to the bill sponsor and all the advocates. I know that you've done a lot of work on this bill. And I just had a comment and then a question. So my comment is I do think it's important that we keep that definition consistent because there are multiple states that are utilizing it. And as much as we are able, I think we need to keep that definition consistent across the states. But my question is when we get to the language around the definition of manufacturer, and this might even be a question for our council, is that defined in code somewhere? And if so, could we put like a limitation like for this section if we did want to further limit the definition of manufacturer within this bill?
I'd have to look into that for you.
Okay, thank you.
Sure.
Thank you. Are you done, Delegate? Okay, thank you so much. Delegate Hill.
Thank you, Madam Chair.
My pleasure.
So for me to get clear, Mr. Hubert, when you talked about the European Union and the 5 years, how far are we into those 5 years? Are we in year 1 and we've got 4 left? Are we in year 3 and there are only 2 left? So if we're going to catch up with them, how many years are we talking about?
Well, it's pretty much unknown at this point. I know that all of the manufacturers are working to fill those gaps that I've identified. Some of it can be done through different application techniques, but that will require re-engineering and I said perhaps infrastructure changes. If you have to suddenly increase the application rate by 1.5 times or 2 times, you may not have enough water available to do those types of things. So, I mean, in the ideal world, we'd be there within the next 2 or 3 years, but it's unknown.
So maybe, I guess you referenced both in your testimony in the hearing and today that the European Union is given 5 years. What I'm trying to find out is how many years are left in the 5 years that they gave.
Oh, they just recently did that within the last year.
Okay, so they got about 4 years
About
left.
4
If we
years,
Past
yeah.
this, we would be consistent with their timeline if we said you have 4 years.
Correct.
Okay, and then Ms. Locklear, I have a quick question. You had made the statement that you wanted to narrow the manufacturer's definition, and you gave the example of food repackagers, and you said you want to make sure they're out of it. And I want to be clear, if all we're doing is making sure that they can comply, so if in the example you gave, if the store is repackaging meats, they get it, and the store gets a choice about whose packaging it buys, and they have therefore the agency to buy PFAS free, right? So if we want to motivate them to make the choice to buy PFAS free stuff, then that would be okay to keep them in the bill. You're just talking about when they don't have agency about the products they use to repackage. Is that, do I have you right? Or you can keep them out regardless of their agency?
Yeah, kind of. So, I mean, there's a bunch of things that could happen here, right? Like we are just not going to have this capability. And quite frankly, when I asked even our largest retail members in the United States, how would you even go about testing for something like this? Apparently, sometimes they use third-party labs. But then the response that they got back from those third-party labs is because of the thousands of chemistries for PFAS, the labs that they use came back and said that they weren't going to be able to identify the chemical. So that's one part of this issue. The other part is that you're putting a penalty on this bill for us or the distributor or the manufacturer, because that definition is so broad, when someone in the supply chain could say, hey, there's no PFAS in this, and there actually is. And so I mean, we just have multiple concerns around that because that manufacturer definition is so broad. When you're just putting a label on a product, you get caught in this bill. And to your point, sure, I'm absolutely sure that there are suppliers out there. But what I'm hearing back from my larger guys is I don't think we're there yet in the United States. And there might be other folks that can speak to the supply chain issues and what is available to us. And that's one of the reasons we initially asked for the implementation date to be pushed out too.
Okay, so when you talk with Delegate Love, this is why, because I know we've done it with the cosmetic testing on animals.
Yep.
We've done it with other things that we've had to ban where people say, how am I supposed to know what's in it? And we did it, with plastics. And the answer was you ask the people you buy it from and they can generally tell you. So I don't think anybody in this bill was thinking that everybody would have to test their stuff for PFAS. It's just that they're mindful. And so when the sponsor, at least my understanding, maybe yours is different, that's why there's a question here. My understanding is when she says knowingly or should have known, it means that they take the time to ask, is there PFAS, and where that their supplier said, and as far as we know, it's PFAS free, and then they go, okay, then we can get it.
Yeah.
Thank you. And you can answer that. I mean, that's my understanding. I think it's
no, I understand the point. And then I think the question does become, what does supply look like in the United States? And this is where I went back to having this conversation with some of our larger grocer members. And I'm not sure that supply is there for non-PFAS items. And either way, just that definition is too broad. I understand your point. And I'll look into that and I can circle back with you.
Thank you. Next, we have Delegate Rosenberg, followed by Delegate Riley.
Do we need the same time period, whether it's 5 years, 2 years, whatever, for all PFAS products? Or is an alternative, the safer alternative, available for some of the products in a shorter period of time?
May I answer, Madam Chair?
Absolutely. 1 second. Delegate Rosenberg, who said, may I answer?
That was me.
Okay, absolutely.
Thank you. Thank you. Delegate Rosenberg, the 2-year pushback that I gave you all before, as I said, was based on what a number of other states are doing that have this exact same law. So there are other alternatives out there. The industry is moving this way. I mean, we have a whole host of, we have a whole list of stores and manufacturers and fast food industries that are moving this direction. So there are alternatives out there, and the 2-year timeline should give them more than enough time to transition.
Thank you.
Thank you. Delegate Riley. Delegate Hill, is your hand still up? It's up. Thank you. Delegate Riley.
Thank you, Madam Chair.
My pleasure.
Yes, my question is for Mike Ratchford. And my question is, I think the definition in your amendment, your proposed amendment that I'm putting forth is kind of misunderstood a little bit. I just want you to clarify, just so that our audience would know. Your definition of PFAS, it does not change the current bill's reference to any of the products that they want to ban, does it?
That is, yes, that's what I'm suggesting. So what we're trying to do is draw a distinction between polymers and non-polymers in that. And a number of the PFAS that were used in the products that we talked about here tonight had used non-polymer PFAS going forward. Again, our intent with all this would be to recognize the distinction between fluoropolymers, our products, and products that would be non-polymers, or those that would be of concern. I can't speak exactly to the chemistries of all the products because we don't make all those products. But my understanding is historically, and Mitch Hubert probably knows this better, that legacy firefighting foam contained PFAS, I believe, and they're since looking to move away from that. So trying to draw a distinction there is what we're attempting to do.
Okay, thank you so much for the clarification. Appreciate it. And thank you for coming this evening.
Thank you.
Jeff.
Yeah, I think just to respond to Delegate Riley's just inquiry with W.L. Gore, one of the issues with the definition change is that it would open it up so that there are currently AFFF foams on the market that are available now that if you change the definition, they would then be available again. I don't think that's necessarily W.L. Gore's issue, and I don't think they're raising an issue with that, but the issue with the definition change is it would apply, if you change it, it would apply to the foam, and then there would be AFFF foams that are available on the market that wouldn't be banned under the revised definition, and that is our concern with it.
Any other questions from our guest, from anyone? Our guest meaning everyone here invited? No? Delegate Hill, you have the last question before I speak?
Yes, the gentleman who just spoke and I didn't see, I think it was Mr. Buttle. No, it wasn't Mr. Buttle, but whoever just spoke. So do they have a?
It was.
Okay, so do you have can you come up with a recommendation that includes what Gore is asking for, but closes the door on reopening or letting things back in that we haven't? I mean, can you come up with a recommendation for something that threads that needle?
Yeah, I actually think we've been working with the bill sponsor to craft some language that would address just what you're asking.
Thanks.
Ms. Carr, and this is really the last question.
Yeah, and I just
before
want to,
speak.
yeah, the concern of the definition is beyond just the foam, right? If we suddenly change the definition to allow fluoropolymer or PFAS, even if they have not been used historically in rugs and carpets or food packaging, that would just leave the door open for those chemicals to start being added to those products. So we want to avoid that. So yes, we're working on hopefully some agreement to be clear on where the definition applies, but we don't want to create a loophole big enough to increase the likelihood that fluoropolymers end up in places we don't want them.
So I think everyone has spoken. So I just want to take a few minutes to say a few things. I appreciate everyone that has come tonight. I appreciate the bill sponsor for working with the industry and the advocates. I love your passion and your leadership. As a public health committee, we try to find a balance here. So the fact is that PFAS chemical have been turning up, in drinking water and in all the items we have discussed today, and also the products that are firefighting, men and women, what they're exposed to with the phone and everything, the equipment, and it has been linked to non-Hodgkin lymphoma, kidney, testicular, prostate, breast, liver, and ovarian cancer. The science is clear. So what's also very clear as we're looking for this balance, right, to try to find language that is used in other states that have already done it, because Maryland won't be set first, second, third, fourth, fifth, or sixth, or seven, maybe seven. Actually, no, not seven, not eight, probably, is the fact that it's being done. So you have the same definition being used here in California, Connecticut, Colorado, Maine, Minnesota, and Vermont. That's 6 states already. Then you have same definition with limiting clauses used in New Hampshire, New York, and Washington, right? So while I'm listening to all the concerns regarding the private label, not having something to substitute it with, the fact is that these states are doing it and other, countries are doing it, which means that they have a lot of smart people that have come together and have looked at it. So what I would advise you respectfully is to try to find, a definition, even if you compromise on the definition with limiting clause, right? That would address some of the concerns of the industry, because we also respect you in Maryland and we want your business, right? And people are employed, but we also love our firefighters and we love our people not getting cancer, right? So it's finding that delicate balance, which can be done by using the language that is in another state, sitting down and looking at it and compromising, because it's being done already. So I hope that you do that. I am optimistic that you will do so because you're at the table and you have other models, other states and language that have been doing it. So I would like to point you towards the same definition with limiting clause so that your concerns are addressed. And perhaps that's the way we'll do it in Maryland as well. So I am optimistic. If you need help, let me know. I am available. If you want to work with anyone from the committee as well, these are, my colleagues are smart people that care and are willing to, all of them, help and see if we can get to some compromise. Thank you so much for your time. I do appreciate it. To the committee members, I know it's later than I wanted you to be here tonight, but this was needed. So thank you so much for caring, for being here tonight and for your service. And Aaron and, Edith, thank you so much for being with us today, okay? I hope you get to have some dinner and I hope you have a blessed evening. Have a blessed evening. Take good care.
Bye. Thank you.
Bye-bye.